Yeah, you can start.
Good evening, everyone. I'll be talking about the drug Propofol today, and more specifically in status epilepticus. So in 2018, the Clinical Research Award, Lasker DBK Award, went to John Baird Glenn. And this is the man who changed the field of anesthesiology with the invention of Propofol. He discovered Propofol, and it has changed the way anesthesia has evolved over the last few years. And the other reason Propofol has been in the news recently, if people remember, this was the drug that killed Michael Jackson. He had used it. His physician had given him a higher dose to help him sleep, and he was left unsupervised. Now, coming to Propofol, I'll be talking under these following headings: the structure and mechanism of action, pharmacodynamics and pharmacokinetics, drug interactions, Propofol in special populations, general indications, Propofol in refractory status epilepticus, contraindications, adverse effects, and a little about refractory status and where exactly does Propofol fit in the algorithm. Now, Propofol is
I don't
chemically
see the slide moving. I don't see the
uh,
slides moving. Can you?
now, sir.
I don't
Is it
see
moving now?
the presentation at all. And there may be a lag for a few seconds. Not for me. Other
Uh,
attendees may tell us.
are the slides moving now?
No, I still see the invitation slide.
Okay, let me
Can you make it full
just
screen?
share again. Now,
I still see the invitation slide. Can you go to the next slide? Yeah, it's
yes,
moving.
sir.
Yes, now
It's
it is
moving.
moving.
Okay,
Continue.
when I go to the full screen, it's not moving, so maybe I'll just play it like this.
Sure.
Okay. Propofol is chemically described as 2,6-diisopropyl-phenol. It is a short-acting, lipophilic, intravenous general anesthetic. It is an oil at room temperature and is barely soluble in water. Less than 0.1% is ionized at physiological pH. That is why the formulation contains soybean oil, glycerol, egg lecithin, disodium edetate, and sodium hydroxide to adjust the pH. With this formulation, it is isotonic and has a pH of 7 to 8.5. The soybean oil dissolves the propofol, glycerol maintains the isotonicity with blood, and egg lecithin makes the emulsion stable. The size range of the stable droplets in the vials refract light and creates a milky color. Therefore, it is known as milk of amnesia. In vivo, the propofol diffuses from the oil droplets into the bloodstream and then into the cell membranes with rapid equilibration with the brain neurons in less than a minute. The small droplets means there is a large surface area for rapid diffusion out of the soybean oil droplets. The mechanism of action. So propofol enhances the GABA mediated transmission through ligand-gated GABA A receptors. Propofol acts at a location other than the benzodiazepine binding site. It binds to the beta subunit of the postsynaptic GABA A receptor and causes an inward directed chloride current that hyperpolarizes the postsynaptic membrane. At low concentration, it potentiates this ligand-gated channel. At higher concentration, it directly activates the channel opening. So this is the GABA receptor. So here is a propofol binding site. It also, to a lesser extent, blocks the NMDA receptor and thus there's a reduced glutamagic activity. And also it is found that it diminishes calcium influx via slow calcium ion channels. So generally propofol is used as an intravenous general anesthetic and sedation drug. It is used for the induction and maintenance of anesthesia or sedation because it has a very rapid onset of about 40 seconds and the half-life of the blood-brain equilibration is 1 to 3 minutes, and it has a short duration of action up to 15 minutes, making it a very favorable drug for anesthesia. It also possesses sedative, anxiolytic, and anticonvulsant properties. It may have beneficial anti-inflammatory and antioxidative effects and neuroprotective properties, including reduction of intracranial pressure. Pharmacodynamics. On the cardiovascular system, it can cause arterial hypotension, sometimes greater than 30% decrease in blood pressure. Pharmacodynamically, the studies have shown no or little or no change in heart rate and no decrease in cardiac output. However, when we come to the adverse effect, I'll explain as to how it can cause bradycardia in some patients. If ventilation is assisted or controlled, there is an increase in the incidence and degree of depression of cardiac output. There is an anti-emetic effect where propofol interacts with the D2 receptors in the chemoreceptor trigger zone. It inhibits the limbic system and inhibits the 5-HT3 receptors in the CNS. The neurophysiological effects, it decreases cerebral blood flow, it decreases intracranial pressure and cerebral metabolic rate. However, it maintains the dynamic and static autoregulation. Respiratory system, it is a potent ventilatory depressant by affecting the central chemoreceptor sensitivity, reducing the ventilatory responses to hypercapnia and hypoxia, and at higher doses it can cause apnea. Propofol infusion is also known to cause green skin and urine discoloration caused by the production of the phenol green chromophore. Pharmacokinetics. Propofol is only suitable for intravenous use. It is not suitable for enteral route due to its bitter taste and low oral bioavailability due to a high first pass effect and the high hepatic extraction rate. It is extensively bound to plasma proteins, that is mostly albumin and erythrocytes, and that is why the free fraction is only 1.2 to 1.7%, and most importantly, it readily crosses the blood-brain barrier. Following an IV bolus, there is a rapid equilibration between the plasma and the brain. The plasma levels will initially decline rapidly due to the distribution as well as metabolic clearance. The distribution decreases as body tissues equilibrate with the plasma and become saturated, and this distribution half-life is about 2 to 4 minutes. During elimination, the decline of the blood level is slower and it can be up to 30 to 60 minutes. This is because longer infusions results in accumulation of tissue stores of propofol. The terminal half-life of propofol after about a 10-day infusion is 1 day to 3 days. So this is the pharmacokinetics. This is after 1 hour, 10 hour and 10 days, and this is the time to awakening. You can see that within minutes there is a rapid awakening and the rapid fall in the blood levels. Even after 10 days, the awakening time is not very long. However, the half-life is generally prolonged. Metabolism. The liver is very efficient at propofol metabolism with a blood extraction rate of 90%. Because of this, propofol metabolism depends critically on maintained hepatic perfusion. CYP2B6 and to a lesser extent CYP2C9 are the major catalysts. So most of the propofol, about 70%, by the action of UDP glucuronate forms water-soluble propofol glucuronide, and about 29% is hydroxylated to form water-soluble sulfate esters. The kidneys can also contribute to propofol metabolism, and they can have an extraction rate of about 60 to 70%, and to a small extent by the small intestines as well. After metabolism, 88% is excreted within 5 days in the urine. Less than 0.3% is excreted unchanged. The phenolic metabolites rarely results in the green discoloration of the urine. It is also excreted through exhalation, that is very small quantity of propofol metabolites. Coming to elderly patients, with increasing patient age, for a given IV bolus dose, higher peak plasma concentrations occur. This is because of a decrease in volume of distribution and intercompartmental clearance. And this can predispose these patients to increased cardiorespiratory effects, including hypotension, apnea, airway obstruction, and arterial oxygen desaturation. The safety of propofol during pregnancy has not been established. Propofol crosses the placenta and can cause neonatal depression. Hence, it is not recommended to be used. Breastfeeding, small quantities are excreted in human milk. Women should therefore not breastfeed for 24 hours after administration of propofol. Milk produced during this period should be discarded. Drug interactions. So any drugs that act as sedatives and a cardiorespiratory depressive effect, the effect of propofol with these drugs will be multiplied, and there's a synergistic effect with drugs such as morphine, meperidine, fentanyl, benzodiazepines, and barbiturates. In pediatric patients, administration of fentanyl concomitant with propofol may result in serious bradycardia. Profound hypotension following anesthetic induction with propofol is seen in patients treated with rifampicin. A need for lower propofol doses has been observed in patients taking valproate, and in patients having on cyclosporin, there have been cases of leukoencephalopathy reported. Combination with succinylcholine or neostigmine can result in bradycardia and arrest because of the vagal effect. So these are the general indications of a propofol, which I will not cover in detail because that's not the topic today, but these are the FDA approved indications. That is induction of anesthesia, maintenance of anesthesia, induction above the age of 3 years, maintenance above the age of 2 months, and sedation in ICU and procedural sedation and monitored anesthesia care. Now coming to propofol in refractory status epilepticus. Now, the first discovered that propofol can be used as in epilepsy when they were using it as an anesthetic in patients undergoing electroconvulsive therapy. They found that the seizures induced by ECT lasted for a shorter period of time if propofol was given. After that, propofol was tried in various studies for status epilepticus and was found to be successful. It is now an off-label indication for refractory status epilepticus. Propofol is widely used as one of the first-line intravenous anesthetic agents for refractory status because it allows rapid titration. It has a short duration of action even after prolonged infusion. The control of clinical seizures associated with propofol alone has been reported to be 67 to 88.9% of cases of refractory status. So what is the dose that we use for status epilepticus? The loading dose is 1 to 2 mg per kg, followed by 0.5 to 2 mg per kg every 3 to 5 minutes until seizures are suppressed. Now these bolus doses can be given to a maximum total dose of 10 mg per kg. After that, we need to start as a continuous IV infusion. So the initial rate of infusion is 20 microgram per kg per minute. So this is titrated upwards till there is cessation of electrographic seizures or burst suppression. So the usual dose range is about 30 to 60 micrograms per kg per minute, which roughly works up to 1 to 4 milligram per kg per hour. The maximum dose that you can go up to is 200 microgram per kg per minute or 12 milligram per kg per hour. You have to use caution when you are using more than 4 milligram per kg per hour for more than 48 hours. Why this is so, we will come to it later. It is mostly because of the risk of propofol infusion syndrome. When on an infusion, if the patient has breakthrough seizures, you can administer additional bolus of 0.5 to 2 milligram per kg every 3 to 5 minutes and also increase the infusion rate by 5 to 10 microgram per kg per minute every 5 minutes. Be careful while titrating in patients with unstable general conditions, with impaired cardiac, renal or hepatic functions or hypovolemic patients. The cardiac, circulatory or pulmonary insufficiency and hypovolemia should be corrected or should be compensated before administration of propofol. After starting propofol, IV fluids and vasopressors can be used to support the blood pressure. Titrate the infusion till seizures have stopped or burst suppression is induced. Infusion rates of up to 10 to 12 milligram per kg per hour may be required. It should not be maintained for more than 48 hours because of the risk of propofol infusion syndrome. Once the seizures are controlled, The effective infusion rate should be maintained for 24 hours and then try and taper it down at a rate of 5% per hour. This prevents the rebound seizures. It is critical that before we start reducing the dose of propofol, high therapeutic levels of at least one or more long-acting anti-seizure medications are maintained prior to this. Treatment with propofol should be considered unsuccessful if it does not terminate the seizure activity within 45 to 60 minutes. In this case, switching to or adding a benzodiazepine drip or switching to a higher dose barbiturate infusion may help. So this is about propofol in refractory status epilepticus. Now coming to the administration. So propofol is given only in hospitals or adequately equipped day therapy units by physicians trained in anesthesia. The circulatory and respiratory function should be monitored and there should be facilities for artificial ventilation. In refractory status, it is generally given once the patient is on a ventilator. It comes as a sterile, non-pyrogenic emulsion containing 10 mg per ml of propofol. Each 20 ml will contain about 200 mg and so on. 50 ml 500 and 100 ml 1000 mg. So first inspect it visually for particulate matter and discoloration prior to administration. Shake well before use. Do not use if there is evidence of excessive creaming or aggregation or if larger droplets are visible. Slight creaming should disappear after shaking. Propofol is to be used undiluted, but if necessary, can be diluted. But for the infusion, always use volumetric infusion pumps. It should be administered through a filter with a pore size of 5 micron or greater and should not be administered via a microbiological filter. If dilution is necessary, it should only be diluted with 5% dextrose injection to a minimum concentration of 2 mg per ml. And in the diluted form, it is found to be more stable in a glass container. Strict aseptic techniques must always be maintained during handling. It is a single-use product and it contains 0.005% disodium editate to retard the growth of microorganisms in the event of an accidental contamination. However, it can still support the growth of microorganisms as it is not an antimicrobially preserved product, and there have been post-marketing surveillance has found cases of sepsis and septic shock due to infection that is triggered through propofol infusions due to the lack of asepsis. Prior to the use, the rubber membrane should be cleaned using an alcohol spray or a swab dipped in alcohol. After use, all the containers should be discarded. The emulsion must be drawn aseptically into a sterile syringe immediately after breaking the vial seal. Asepsis must be maintained both for propofol induction and infusion equipment throughout the infusion period. Co-administration of other fluids must occur very close to the cannula site using a Y-piece connector or a three-way valve. It's recommended to use a central vein for administration in an ICU setting. Do not administer through the same IV catheter with blood or plasma. The infusion of propofol via one infusion system must not exceed 12 hours. After 12 hours, it must be discarded or replaced even if infusion needs to be continued. To reduce pain associated with injection, use larger veins of the forearm or antecubital fossa. In order to reduce pain, propofol may be mixed with preservative-free lidocaine injection, that is 0.5% or 1%. It can be administered prior or added to the emulsion immediately before administration. And the proportion should be 20 mg per 200 mg of propofol and not more than that because it makes the emulsion unstable. When it is stored, protected from light, propofol undergoes oxidative degradation in the presence of oxygen and it is packaged under nitrogen. It has a melting point of 18 degrees Celsius and should be stored at room temperature. The shelf life when unopened is about 2 years. The contraindications. It is contraindicated in patients with a known hypersensitivity to propofol, contraindicated in patients with allergies to eggs, egg products, soybeans or soy products. There's a relative contraindication in patients with advanced cardiac failure or other severe myocardial disease, especially in refractory status, because here we generally need to give bolus doses and higher doses to maintain burst suppression or for control of seizures. and a caution when patients have disorders of lipid metabolism. The other adverse events are pain at the injection site. There could be an early pain due to endothelial irritation, but also delayed pain has been described due to the activation of TRPA1 and TRPV1 stimulation, which are the transient receptor potentials, and this causes the release of CGRP, a vascular leakage and dilatation, and neurogenic inflammation. Propofol can also cause hypotension. It can cause up to more than 30% decrease in the MAP. This results due to a reduction of peripheral resistance through a direct action on the vascular smooth muscle, inhibition of sympathetic activity, and reduction in the volume caused by decreased venous and arterial resistance with no change in cardiac output. And a minimal effect against the calcium channel. It can work as a calcium channel blocker and a beta adrenergic antagonist. The other cardiac side effects, there have been reports of bradycardia and also asystole. So the intravenous administration of an anticholinergic agent before or during infusion should be considered, especially when patients have an increased vagal tone. It may also be associated rarely with prolonged QT interval on ECG. Hypersensitivity reactions. Propofol may rarely cause anaphylaxis, angioedema, and bronchoconstriction. The immediate hypersensitivity reactions can be IgE mediated or non-IgE mediated, and it is not dose related. So initially, although the FDA package insert, FDA has recommended to add that patients with soy or egg allergy patients have a contraindication for propofol. Many studies have found that these patients can receive propofol, and the actual allergy is due to the presence of diisopropyl side chain or the phenol group. Hypertriglyceridemia. So propofol is an emulsion that contains lipid. So this again is dose and duration related. And rarely this hypertriglyceridemia can lead to acute pancreatitis. It may occur at any time, but the median time ranges from 2 to 4 days. Also, because of the high triglycerides, the high fat content, there's a caloric value of 1.1 kilocal per ml. And especially in ICU patients, this should be taken into consideration while calculating the total calorie requirement. The CNS side effects, common as headache during the recovery phase. Rarely they have found that there's seizure-like phenomenon such as myoclonus, convulsions, and opisthotonus in about 30 to 40% patients, either during induction or withdrawal, or it may be delayed up to days, but it is not seen during the maintenance phase. Very rare, this is more in terms of when it is used for anesthesia, this post-operative unconsciousness. The propofol-induced movements are considered to be peripheral in origin, especially the myoclonus and opisthotonus, or due to the lack of cortical inhibition. When you give a small dose of non-depolarizing muscle relaxant, it may reduce, which helps to distinguish myoclonus of peripheral and central origin. Coming to the most dreaded complication because of which propofol has not been used as widely as it was once considered as a good drug is the propofol infusion syndrome. So the first reported death associated with propofol infusion was of a 3-year-old girl in Denmark in 1990. So it first appeared in pediatric literature and later adult cases were also described. The incidence is approximately 1.1% to 4.1% and the mortality rate is 18 to 33%. In many studies, they have found that the risk of this infusion syndrome is high when patients are on more than 4 mg per kg per hour propofol infusion for more than 48 hours. So this syndrome is characterized by severe metabolic acidosis, hyperkalemia, lipemia, rhabdomyolysis, hepatomegaly, renal failure, ECG changes with cardiac failure. So the cardiovascular manifestations are a widening of the QRS complex, Brugada syndrome-like patterns, which is a coved ST segment elevation, ventricular tachyarrhythmias, cardiogenic shock, or asystole. The skeletal muscle manifestations are myopathy and overt rhabdomyolysis with elevated CPK. The metabolic effects are high anion gap metabolic acidosis due to the elevation in the lactic acid. And hepatic manifestations include liver enzyme elevation, hepatomegaly, and steatosis. Now, why does this happen? We know that in a critical state, the body breaks down a lot of fat, and fat is an important requirement for energy, especially for the brain and for the heart during this period. They have found that propofol can inhibit this oxidative phosphorylation. It uncouples the oxidative phosphorylation. It has an effect on the electron transfer in the mitochondria and also inhibits the carnitine palmitoyl transferase, because of which the fatty acids cannot enter the oxidative phosphorylation pathway. And because of this, there is an increase in the fatty acids and more lactic acids are formed. So it is a multifactorial state where you give propofol for a long duration in a state where patients are genetically susceptible and have critical illness with low carbohydrate state, increased free fatty acids because of the uncoupling of the oxidative phosphorylation results in a metabolic acidosis. It results in a proarrhythmogenic state, a cardiac dysfunction, and a renal dysfunction, as well as rhabdomyolysis. So the risk factors are critical illness, high dose, duration of therapy more than 48 hours, addition of catecholamines and corticosteroids, severe head injury, airway infection, very young age, low carbohydrate intake or high fat intake, or inborn errors of fatty acid oxidation. So this is a clinical diagnosis and these constellation of symptoms and signs and requires a high index of suspicion and careful monitoring of the lipid levels, of the acid-base balance, of the renal functions, the creatinine levels, the creatinine kinase levels, as well as liver functions. So this is all about propofol, but where exactly do we need it in the treatment of status epilepticus? Now I'll just go through briefly two guidelines. One is the Harvard guidelines and Oxford guidelines. Now many clinics such as the Mayo clinics and certain centers do not prefer propofol because of the they have found that there was a higher risk of propofol infusion syndrome, whereas several centers including Harvard and Oxford do recommend propofol as one of the first IV anesthetic drugs for refractory status. And for us as neurologists, where exactly to use propofol and how to use it is important. So we know that now status epilepticus is defined as ongoing seizures or recurrent seizures without complete recovery of sensorium for more than 5 minutes. So the first line is benzodiazepines, lorazepam 4 mg or diazepam or midazolam. And if the seizures persist, we start the second anti-epileptics, that is either valproic acid, levetiracetam, phenobarbital, phenytoin, fosphenytoin, or lacosamide. So these are all the drugs that are recommended presently. So if the seizures still persist after a first line of benzodiazepines and an appropriate dose of a good anti-epileptic drug that is mentioned above, then the patient is said to be in refractory status epilepticus. So in refractory status, we choose the anesthetic drugs. So in the Harvard guidelines, you can see that it is either midazolam or propofol. Both have been considered, although they have mentioned midazolam as the initial drug. So midazolam, propofol, the same dose as I mentioned, 2 mg per kg IV, and repeat every 5 minutes till the seizure stops. Maximum loading dose of 10 mg per kg, the infusion of 1 to 10 mg per kg per hour. Titrate the infusion to stop the seizures or induce burst suppression. Burst suppression for the residents is when we maintain a continuous EEG monitoring. The patient is sedated and on an anesthetic, so we may not be able to see the seizure activity. And sometimes they'll be also paralyzed because of the ventilator support that is required. So on the EEG, burst suppression is the absence of electrographic activity, and we see high amplitude activity that is seen in bursts, and in between there is no electrographic activity. The exact burst suppression interval that is required is not defined, but generally 5 to 10 seconds is considered important. So whether to go in for absence of seizure activity or burst suppression is not clearly defined. Most of the time, initially, when we start the anesthetic, we try to attempt a burst suppression, and then on reducing, you try to maintain a seizure suppression only. So once the patient is seizure free for more than 24 to 48 hours, then start the slow taper of the IV anesthetics while maintaining the therapeutic levels of anti-epileptic drugs, and continuous EEG monitoring till the patient is off IV anesthetics. So what happens if it is super refractory status? Super refractory status is when the patient has been on IV anesthetic drugs for more than 24 hours and the patient continues to have seizures, or while trying to taper the IV anesthetics, the patient develops seizures. This is called as super refractory seizures. So you can continue the doses of IV anesthetics to induce burst suppression, add other anti-epileptic drugs, magnesium, ketamine as an anti-NMDA antagonist that is considered as one of the add-on drugs, thiopental sodium, IV pyridoxine, and immune modulation such as steroids, IVIG, or plasma exchange. Then we can consider a multidisciplinary approach including ketogenic diet, therapeutic hypothermia, if required, surgery, and so on. So the IV anesthetic drugs that are generally considered are midazolam, propofol, thiopental, and ketamine. So initially only thiopental was available, and most of the studies that have been done on thiopental, that is the barbiturates. However, there is a lot of cardiorespiratory depression and hypotension. So generally now one of the drugs, either midazolam and propofol, is generally considered as first line IV anesthetic. If not responding to either midazolam or propofol, you can consider thiopental sodium or ketamine. I won't go into details of all the drugs. So this was the Oxford Hospital guidelines, which shows that if the patient has refractory status epilepticus, they prefer propofol if propofol is not contraindicated. If contraindicated, start midazolam. Propofol bolus of 1 to 2 milligram per kg, followed by continuous infusion at 1 to 5 milligram per kg per hour for burst suppression. If burst suppression is achieved, continue. If there is a breakthrough seizure, you give propofol bolus at 1 milligram per kg and increase the infusion rate at 0.5 milligram per kg per hour, and continue this till maximum dose of propofol is achieved. If there are still seizures, start midazolam, or if burst suppression is not achieved, start midazolam. So midazolam in addition to propofol, midazolam bolus of 0.1 to 0.3 milligram per kg, followed by continuous infusion of 0.05 to 0.4 milligram per kg per hour till the ictal discharges are suppressed, and increase till the maximum doses. If still not controlled, start thiopental. If controlled, maintain the infusion for 24 hours seizure-free period. And after thiopental, again try to achieve burst suppression. If burst suppression is achieved, then maintain it for 24 hours. If not, further boluses till maximum dose. If on maximum dose you continue to have seizures, consider ketamine. If on ketamine, even on the maximum dose it is not achieved, then we'll have to consider other multidisciplinary therapy and other approaches. Thank you.
DELON, thank you very much. It was a very nice presentation. You have covered all the practical aspects as well as the basic mechanisms of this drug. Very nicely you have covered. A lot of practical tips have been given. We'll spend next few minutes in discussion. I think our ICU colleagues are also there, and they are welcome to make any comments and suggestions. I think one of the important things is the valproate. Nowadays, valproate also is being used in the treatment of status epilepticus. And once the patient has received valproate and you plan to start propofol, you have to remember the interaction, the increased propensity for toxicity. I think that is a very important interaction. The other problem is the seizure-like phenomena. What happens is when we give the drug, patient develops few jerks or movements or posturing, then we may mistake it as a seizure and continue to hike up the drugs. I think that can push the patient into propofol infusion syndrome. So that also has to be remembered. Right? And there is a Cochrane review comparing the three drugs in 2018, I think, by an Indian author. And that has shown that there is no big difference between the three agents. But the mortality could be a little more with propofol than with midazolam. And the duration of ventilation is longer with thiopentone. I think 3 weeks with thiopentone and about 10 days with propofol. That is the difference. But ultimately, mortality and seizure remission rates, they are not different. So that is the conclusion. Correct? No? You are saying something.
Yes.
Please go ahead.
Yes. No. Yes, sir. The same thing. Actually, they found that defectivity-wise, A lot of studies have compared propofol with either midazolam or thiopentone. Propofol is always found to be reducing the time required, and however, barbiturates, that is thiopentol, is found to be more effective, but higher degree of hypotension and longer requirement for ventilatory support.
Right. And another data that is coming out is that ketamine, if you use earlier, it is better. Instead of spending time on these same old agents, ketamine is found to have a very good effect. So maybe we should push it up in the order of usage. Right?
So they're saying that it has a synergistic effect because all these are GABA mediated, and that is NMDA antagonist. So that way there'll be a synergistic effect with the IV anesthetic and ketamine.
Also, there is a double-edged sword with propofol. It reduces the ICP, which is good, but it also reduces the blood pressure, so the perfusion goes down. So especially in heavy patients, it is dicey. We don't know how this affects the cerebral perfusion. So such complicated cases, you need to have the ICP monitoring and things like that. You need to be careful about this. Right? Another important thing is that microbiological filter, because this is a lipid emulsion. We should not put a filter, so this also will get filtered out. So
Yes.
we should remember that not to use the microbiological filter by using this. Any other comments are welcome. Yeah, seizure worsening is also reported. Actual seizure, not only seizure-like movements, but seizure worsening has been reported. So that you should remember, right? Dr. Bindu, I think please unmute yourself and talk. Please go ahead, Dr. Bindu. Hello.
Ma'am, I think you need to unmute.
We can't hear you, Dr. Bindu. Okay, now type your message, Dr. Bindu. You're not audible. This is a problem with her audio.